It gives me an immense pleasure to invite our course director for today, Dr. Subhash Kaul sir, who is a senior consultant and stroke specialist at KIMS Foundation and Research Center, Sikandrabad. Sir is associated with Nizam's Institute of Medical Science, Hyderabad for more than 27 years and also has served as professor and head of Department of Neurology as well as dean at NIMS. He has around 120 publications in national and international journals and also associated as a principal investigator as well as co-investigator in several national and international projects, including largest single center Hyderabad Stroke Registry, which was funded by ICMR. Sir also had served as a president at AB Neuroscientist Association, Indian Stroke Association, as well as Indian Academy of Neurology in the past, and has won State Teacher Award by Telangana government in 2017. Welcome, sir. Thank you for joining with us today. I would now like to introduce our first moderator for today's session, Dr. S. Meenakshi Sundaram, who is a senior consultant neurologist, Apollo Hospital, Madurai. Sir has over 20 years of experience in neurology and has more than 36 publications in various national as well as international journals. He has presented many papers at various prestigious national and international forums and has received Best Research Paper Award at 10th Annual Conference of Indian Academy of Neurology, Lucknow in 2002. Sir is principal investigator for many international trials in neurology therapy, including trials on refractory partial epilepsy, stroke trials, as well as acute stroke interventional trial and Parkinson's disease trial. He has also contributed to many books on neurology. Thank you, sir, for joining with us today. I would like to introduce our second moderator for today's session, Dr. Rahul Kulkarni, sir, who is a senior consultant neurologist at Mastiksha Clinic and Dinanath Mangeshkar Hospital, Pune. He has been involved in several clinical trials since 2006 and has several publications in national as well as international journals. Sir has presented papers and posters in many national conferences and also was invited as a speaker at various national conferences. Sir is a recipient of numerous honors and awards in his career and also is actively involved in public awareness programs to spread knowledge about various neurological disorders. He is frequently heard on radio and seen on TV as well, speaking about various neurological conditions, including stroke. Thank you, sir, for joining with us today. I would now like to introduce our eminent speaker for today's session, who will be presenting two cases on acute ischemic stroke, Dr. Anjali Choksi, who is a consultant neurologist at Shalby Hospital, Jabalpur. She is associated with various societies such as International Parkinson and Movement Disorder Society, Indian Academy of Neurology, as well as Functional Neurological Disorder Society. She has more than 20 publications to her credit in national as well as international journals. She is also a co-author of book chapter titled Childhood Dystonia. She has around 8 abstract presentations at various conferences and has won several awards during her career, including Golden AIM Awards for Women Health Care Award Neurologist category 2022. Welcome, ma'am. Thank you for joining with us today. Unfortunately, our second speaker could not join with us today, Dr. S. Fazal Ilahi, due to his professional commitments. So today, Dr. Ankita Choksi will be presenting two cases for us in this session. And with this, I would now like to hand over the session to our course director, Dr. Subhash Kaul, sir. Thank you, sir, and over to you.
Thank you, Prajakta.
Thank you, sir.
I think you are probably for the first time
yes,
in this program.
Yes, sir.
And I think that is the way of life. I think only myself and Meenakshi seem to be the permanent ones here. Otherwise, we have seen everybody moving, but I'm sure someday we also have to move on. That is the life. But we have thoroughly enjoyed this program. And initially, I used to be very keen to know the cases beforehand, that what case is going to be presented. The whole thing I wanted, all the PowerPoint presentation, I would study them. Then I thought that, okay, it's not necessary. I should know the title of it. But eventually I thought, let that also not be there. I didn't insist. Let there be a suspense. So I'm really, at this time, very curious to know what Anjali is going to present. We have no idea about it. And that is the charm of it. You know, Meenakshi will bear me out that in the last more than a year now, every month, we are having fascinating cases. Some are very ordinary. But then ordinary also is something, no? We cannot, most of the cases are ordinary only. But some are very extraordinary. And some are out of the blue. And we have really thoroughly enjoyed. And so welcome, Anjali. You're also first time here. And Prajit,
The second time.
Prajakta.
Presenting
Second time, I think, yeah, first time also. And
I hope
Rahul,
you remember
sorry.
last time. I hope you remember last time I presented.
I know. I
really-
remember. But my memory is not as sharp as yours. That is, but I remember definitely. And Rahul, welcome here. It's so nice to have you here. And
hello, sir.
Hello, Rahul. Nice to see you here. So I think with that, I will hand over to our very eminent moderators, Meenakshi Sundaram, Rahul Kulkarni. Please take it forward. Now, this is already we are 8:15. And we have two cases. I think I'm sure by 9 we'll finish our discussions. So over to you, Meenakshi and Rahul, please.
Sir, very excited. Thank you for giving me this opportunity, sir. Very excited to be part of this program. And one of our heroes, Dr. Rahul Kulkarni, sir, is there. We enjoy listening to him in all talks. So we're going to listen to some really good comments from him. Raring to hear him. So he's a quiz master himself too, sir.
So let's start with the case, Meenakshi. Okay, Anjali, over to you.
Sir, absolutely. And then we can start straight away. Thank you, sir.
Okay.
Okay, good evening, all of you. So without much ado, I'll start my presentation. Hope my slides are visible.
Yeah. You have to make slideshow. Yeah, good.
Yeah. So I will be presenting two cases. My first case is about an uncommon stroke etiology. So my patient was a 60-year-old gentleman who presented with complaint of weakness of left upper limb and lower limb for last 8 hours, which was associated with slurring of speech. He was non-diabetic. He was not a known case of hypertension. He had a history of disease sibling due to coronary artery disease at the age of around 58 years. So when he came, his BP was 140/80. He had a UMN type of facial weakness. Power on left side was 3/5. On right side, it was 5/5. His NHS score was 6, but he was well outside the window period. So we did the MRI, and it was nearly normal. So there was no acute impact on MRI on DWI ADC images as shown. So we started him on dual antiplatelets along with the statins, and we started working up him for the stroke. So we did the CT angio, and to our surprise, you will see the images. I would like to have expert opinion regarding the images. So any comments from the experts?
Is this CT scan?
This is yes, sir, and this one is the CT angio, and this is also CT angio.
Some large basilar ectasia, ma'am.
Yes, sir. So the basilar artery course is tortuous with diameter of more than more of around 6 millimeter, and there was a eccentric plaque with the cause which was causing stenosis of around 50%. So after this, during the course of hospital, the patient started developing increasing weakness. When he came, his power was around 3/5, but he started developing increasing weakness of the left side with worsening dysarthria. So in view of images of the CT angio, we started him on, because he was already on dual antiplatelet. So we started him on anticoagulation. But over next 48 hours, his sensorium was fluctuating. So we suspected whether he has developed any bleed because of the anticoagulation. So we did the CT angio, but there was no bleed in it. But he continued to deteriorate, and in view of poor GCS, he was ultimately intubated and put on mechanical ventilation. When he came to us, his power was 3/5. He was well conscious, oriented. He had some dysarthria, but over next 48 to 78 hours, he deteriorated badly. And then we repeated MRI on day 6 after intubation. It revealed an infarct, acute infarct in the lower pons. So dilemma that we faced in this case is the role of extend, whether we could have thrombolized him when he came, but he was outside the window period already 8 hours into the weakness. We don't know whether we should have started anticoagulation at first place or not, or if any interventional procedure could help us in such cases. So I would like to ask the expert opinion regarding this.
No, I think it is a difficult situation. You can do any one of them. For instance, let's take extended thrombolysis. The limitation with extended thrombolysis is that the extended thrombolysis, if we are talking of IV extended thrombolysis,
Yes. Yeah.
then that trial has not been done on posterior circulation strokes. That is done on MCA only. You know, it was one subset of extend trial actually, in which you can give up to 9 hours, but provided you do perfusion imaging. So first of all, you don't have perfusion data available, and second is that it is a posterior circulation stroke. So therefore, that would be a difficult thing to do. You know, that will be totally non-evidence based. Second is anticoagulation versus DAPT. But you gave full dose low molecular weight twice a day or once a day?
We gave therapeutic dose, BD dose.
So that is the right thing to do, because even as per the guidelines, in fact, you took little risk because you gave him anticoagulation and DAPT. But that is if you go by the today's guidelines, that is the right thing. That if there is any clot, you can give heparin. If you suspect the infarct is in the territory of that clot, that is the only indication. It's 2B indication for heparin. So I think that is right. Now, third is interventional procedure. But there was no complete block seen anywhere, no? So there was no scope. So I think I agree. I mean, I would have done the same what you have done. Yeah. Meenakshi or Rahul?
Yeah, couple of things from my side. Number one, we know that in posterior circulation, especially, small strokes are often missed if you do initial MR. And this has been in the tune of around 10 to 15%. So later MR would pick it up sometimes. So, you know, many times we know that in the posterior circulation, this is 90th of time. Patient comes with internuclear ophthalmoplegia, the MR is normal. You repeat it after 40 hours and you see a very small pontine dot. That's a well-known thing. So small strokes are often missed. The issue here will be, you know, if the patient has got a normal MR, there's no diffusion abnormality. Would you lyse this patient? You know, even if he had come in window. So that's a very difficult question to answer. You know, normal diffusion, would you lyse this kind of patient is an issue. Again, I would agree with Subhash Kaul sir that, you know, in extend trial, it's predominantly for the anti-circulation. Post-circulation, there is no data. Of course, you need multimodal imaging if you have to thrombolyze in an extended window. We have been doing perfusion-based imaging often with the help of the rapid software, and the sensitivity is not very great for the posterior fossa, you know. So I had seen this in number of cases that we don't see any mismatch in the posterior circulation in the CT base. MR we do it and sometimes we pick it up. So again, it's not a very good indication as far as posterior circulation is concerned. So maybe thrombolysis would have been out of question as far as this patient is concerned. I would agree with you. Yeah.
Rahul, you know, since we have time, I would like to ask you the question. Are you doing extended IV thrombolysis with the help of rapid software?
Yes. We are doing it. We are using it in 2 indications, basically wake up and extended window. And then, yes, anti-circulation, it is doing great. We have been able to lyse quite a few. In fact, my resident, she did a thesis on this, on extended window. And then we could do it more often in anterior. Posterior, if there is an issue, it doesn't pick it up in posterior circulation. So I'm not very happy in the posterior circulation.
No, in wake up, actually, even the simple diffusion flare mismatch also helps.
Yeah, of course.
But for extended window,
that's right.
Regularly. That's right. But for this 9-hour thing, it's really very helpful because, you know, if we want to.
Yes.
So you have done some cases. That's very good. So that is very encouraging. Because we are also day after tomorrow, we are, putting that rapid software in our hospital.
Yeah. At present, they're putting a very huge cost, but somehow we are trying to manage at least till this year. I don't know what will happen next year. The cost is huge.
Yeah. Okay.
Yeah.
Meenakshi, your comments.
Madam, the first thing is that the NIHSS would not be very appropriate for this patient because this is actually a posterior circulation stroke. It wouldn't really guide us. If we take the anterior circulation, maybe NIHSS up to 5, we can give dual antiplatelet. Beyond 5, it is single antiplatelet because the volume of infarction is likely to be high. That's the first point. The second point is that, madam, even before this perfusion things and all came, even before this perfusion things came for posterior circulation strokes, even at this window, we have offered to the patient in case they have been worsening. And I have thrombolysis up to 9 hours in posterior circulation with IV. And the mechanical thrombectomy, almost in 2014 or 15, we have done 18 hours window when that was not even approved. So it all depends on what we sit and talk with the family. If they agree, then I think we can take it up. So this is my take on it. And the third thing is that whenever we have a patient in our emergency who has an acute ischemic stroke like presentation, if the MRI is normal and I find weakness, I have always offered thrombolysis to them. I told them MRI is normal. So why do you want to thrombolyze? They tell them that it is not looking like a stroke mimic. If we are sure if it is a mimic, then we walk away. Here in this case, it was stroke was obvious to us. We would have thrombolyzed this patient. As a rule, we have taken half an hour gap because in half an hour, our radiologist does another MRI for us, only the diffusion. The patient is kept waiting there. Half an hour later, we do. The idea is that within 20 minutes of stroke, it should be seen. So many things are there about diffusion. Half an hour later, we repeat the MRI. If it is showing, then everyone is convinced. If it is not showing, then we tell the family, we would like to thrombolyze. We have thrombolyzed also. For normal MRIs, we have thrombolyzed. We have seen that was in one of the patients who had an anterior cerebral artery infarction. The first time when it happened, we offered for thrombolysis. The family did not agree. And then they said, we talked about perfusion. At the time, we had to do a CT perfusion, for which contrast was required. That patient had a creatinine of 1.8. So they didn't agree for the thrombolysis. We didn't do it. But later on, the patient went on to develop dense weakness. So nowadays, we offer to the family that, no, we have to thrombolyze. If they agree, we do it. I think it is all in our own territory to talk to them. What I have done, I'm not sure if it is right or wrong. We'll ask Dr. Kaul, sir. Sir, is it correct to do like, sir?
No, I mean, yeah, if you talk to family and all, that's okay, I think. But rapid gives us much more, confidence to. But otherwise, it's okay. Yeah, Anjali, go on.
Sir, I would like to add one point. Actually, issue is with the arteriopathy, because in atherosclerotic disease, extended thrombolysis is okay, but with arteriopathy, there's a higher risk of bleeding. So the question here is with the basilar artery dolichoectasia, we should do thrombolysis. Forget about the extended thrombolysis. Even the condition thrombolysis is not clearly indicated in dolichoectatic vessel. Although there are case reports, but I don't know whether I would like to ask.
What would happen if there is a dolichoectatic vessel for IV thrombolysis, madam? Is there anything risky?
There is an increased risk of bleeding because if it is an aneurysmal bleed, it may cause subarachnoid hemorrhage. So,
but it's not a contraindication. It's not a
contraindication.
Yeah, definitely. Okay, so.
And secondly, in this case, maybe mechanical thrombectomy could have been difficult, because I don't know what anatomy would be there. But IV thrombolysis, I thought it was not mentioned, at least in any of the contraindication list. Aneurysm, obviously, it is meant that to an untackled aneurysm. But dolichoectasia, I didn't remember reading as a contraindication anywhere, madam. We would have thrombolyzed, definitely. I mean, if that was the only thing which was seen there.
So I would like to discuss dolichoectasia in short. So the criteria is diameter of basilar or vertebral artery more than 4.5 millimeter, or deviation from any portion of more than 10 millimeter from the shortest expected course, or length of basilar artery more than 29.5 or vertebral artery more than 23.5. So these dolichoectatic vessels may present with three sequelae. First is a ischemic stroke, like in our patient, because of the slow flow or sometimes thrombosis inside the vessel, or with the aneurysmal rupture with subarachnoid hemorrhage, and third as a aneurysmal expansion and brainstem compression. So the patient with dolichoectatic vessels who are at risk of ischemic stroke include older age, male sex, arterial hypertension, or any patient with a history of MI. While the risk of hemorrhage is more in female patients or ectasia more than basilar artery diameter more than 6.4 millimeter, or displacement of basilar artery laterally and arterial hypertension, or previous use of antiplatelet or anticoagulation. So these category of patient have higher risk of hemorrhage with dolichoectasia. Thrombolysis, according to the literature, there is a dysregulation of crosstalk among the vascular smooth cells and matrix metalloproteinase and elastic fiber system may be involved in dolichoectasia. So this unexplored mechanism may have a beneficial or harmful effect on thrombolysis, but its studies are still limited. And it is mainly arteriopathy rather than atherosclerosis. So the response to thrombolytic or anticoagulation therapy is not as efficient as atherosclerotic or embolic infarction, and would increase the risk, would increase the potential of rupture. Although there are many case reports of successful thrombolysis in patients with acute infarct with vertebrobasilar dolichoectasia. We speak about the medical management for patient with cerebrovascular complication. Acute management is similar to other hemorrhagic or ischemic stroke patient. But anticoagulation use is controversial, and they say it might increase the risk of hemorrhagic complication. Apart from that, the control of BP and use of antiplatelet therapy along with statins are advised. For endovascular therapy, they say in patient with moderate or severe vertebrobasilar dolichoectasia, which is based on the CT angio finding, we can decide for the patient who are suitable for the endovascular therapy, because patient with a large aneurysm and greater bleeding risk with slow flow and lower velocity, vorticity, and oscillatory flow may benefit from the endovascular therapy. But it should be managed on a case-by-case basis. Other concern in dolichoectasia include if a patient is diagnosed with the dolichoectasia without any stroke, it is recommended to screen for other potentially fatal arterial disorders like saccular aneurysm, abdominal aortic aneurysm, and coronary artery diseases. If the patient is young, we should look for primary predisposing condition like Marfan's, Fabry disease, adult onset Pompe's, which may cause dolichoectasia. And we should do the serial imaging at 6 months and then yearly to monitor for the arterial enlargement. And if the patient is having an arterial dilatation of more than 10 millimeter or interval arterial enlargement of more than 2 millimeter in follow-up imaging, we should avoid anticoagulation and do strict BP control. And this subgroup of patient might benefit from the surgical repair of the vascular defect. So concluding, it is a relatively difficult disease and it always poses a management challenge, although resulting in the poor outcomes in most of the cases, regardless of the treatment modality employed. But still, there is a plenty of room for research on intracranial dolichoectasia.
Anjali, I just have one question.
Yes, sir.
This patient, you showed dolichoectasia.
Yes, sir.
But there was no occlusion as such demonstrated from CT.
No, sir. No.
Okay.
There was no thrombus. There was an eccentric plaque which was occluding around 50% stenosis.
Okay.
There was no thrombus.
So I mean, what you presented is quite understandable. You have just reviewed the literature. But at a practical level, I mean, I would like comments from Meenakshi and Rahul also after that. At a practical level, when a patient comes to us, every patient has a certain risk factor profile, which will decide about the chances of bleeding. For instance, if there's a patient who has got an extensive small vessel disease, he has a higher chance of bleeding. You know, for instance, if there's a patient who is a 95-year-old, he has a higher chance of bleeding. For instance, there's a patient on double antiplatelets, which most of the patients are these days. He has a higher chance of bleeding. Now imagine a patient, if there's a 90-year-old man with double antiplatelet, with small vessel disease, he has a high chance of bleeding, yet we will thrombolize him. You know, that's the point I want to drive. So in fact, if there's an acute ischemic stroke, other than frank brain hemorrhage or infective endocarditis, there is no other contraindication. You know, I'm not talking about the recent surgery and recent head trauma, leave those of them. But if you go only by the strength of CT scan, so even though dolichoectasia may probably give higher hemorrhage, but it is definitely not a contraindication. So if a patient like this comes within window period, I don't think there's any harm in thrombolizing him. The issue here is that if he comes after 4.5 hours, will you thrombolize or not? And in that, you can clearly see the house is divided. Rahul and me will be more cautious and will not thrombolize, but Meenakshi will go ahead and do extended thrombolysis after talking to her. But that is how stroke is. We would more depend on rapid software and all. We have to protect ourselves also. But then that is a thing. So that is your one issue. In dolichoectasia, what is important is that how to do acute stroke. There's no difference in management. They're all same. Whatever is the etiology, other than I told you, infective endocarditis and this thing. The question is about the prevention. And in prevention, it's clearly mentioned. In the acute stroke, actually, the only thing that they have mentioned, if you see a thrombus blocking, you didn't have a thrombus here, you have a plaque. The prevention is antiplatelet agents in this. There is no doubt about it that you have to, even though it's ectasia, you're not afraid it will bleed or not. You would just give them antiplatelet agent. But it's a good case. It's a good learning for us. And over to Meenakshi and Rahul for their comments.
Yeah, good case. I usually would not have given heparin in such anticoagulation in such cases. I would have managed with antiplatelet, maybe moderate BP management. And we know this in posterior fossa, there is always there is always this progressive worsening. But unfortunately, there is no data to say that in progressive worsening, anticoagulation would help. So probably I would not have used anticoagulation. Usually, I tell my patient of brainstem stroke that if it is an incomplete picture, there is a chance that next 48 hours you may worsen, and we have to accept that this is a natural course of the disease. And let's see what is a nadir that you get in your case. So that's what usually I do in my cases. Yeah, and I agree that dolichoectasia probably we would manage in this way only. I agree. Yeah.
Meenakshi, final comments.
Not final, sir. Was this patient hypertensive?
No, sir.
Is that the reason why? No non-hypertensive, no dyslipidemia.
No.
And any kidney disease, anything he had, ma'am?
Nothing. He was completely asymptomatic before this event.
There's some associations. If you look at that, it is hypertension and then ADPKD. Those are the things. Nothing in the ultrasound also, there is no
We did,
cyst or
yeah,
anything.
we screened him for all those things, but there was no renal problem.
And did the patient do well, ma'am, finally?
No, sir, he finally succumbed
Suck.
because of aspiration pneumonia.
Thank you, ma'am. Thank you for teaching us.
And that's okay. Anjali, you should not feel so, disappointed. All stroke patients don't do well. Please remember it. We do our best. In spite of thrombolysis, patients may not do well. This is the field of stroke. It's like that only. There are disappointments, there are successes, there are, hindsights. But this is what makes stroke exciting. I think you did your best. Thank you.
Seeing patient deteriorating from power 3/5 to this state, it was disheartening for all of us. But anyway, we learned from it.
Yeah.
Yes, sir.
Okay.
So
Thank you for presenting, ma'am.
Thank you, sir. So I'll be presenting my second case in short. It's a case where we'll be discussing more about the symptomatic therapy in stroke, which is beyond the antithrombotic therapy, which we always discuss. So
Anjali, one more thing. Sorry, I'm still stuck at the last case. What was his lipid profile, if you remember? His LDL was okay.
Yes, sir. It was well beyond within the limit. I remember from the last case that you said we should add fenofibrate. We should keep it at the lowest limit. So we started him on fenofibrate also.
No, one of the new things which people are talking is that we should aggressively lower lipids if they are high, and even give sometimes those monoclonal antibodies. If we have to prevent progression, of course, there is no evidence-based, but isolated reports are saying to prevent progression. If there's already progression and patient is grade 0 power, then no point. And that's I think Sudhir presented one case in the last 5 meeting. Of course, that was recurrent TIA. And the only thing which stopped those recurrent TIA was the Ripatha. Ripatha is that PC-ASCII monoclonal antibody, and his LDL was some 400, and nothing stopped his TIAs. Finally, he got that Ripatha, which is some 20,000. So he gave it, and they got stopped. So that is something we have to keep it in our mind in some cases. After all, experience from individual cases also sometimes helps in a given situation. Okay, please go ahead.
Did this patient develop hydrocephalus, ma'am?
No, sir. The last MRI that we did was showing that in fact MRI there was no hydrocephalus. He had that infarct in the pontomedullary junction.
Okay, ma'am.
Okay, so starting with the second case. So this patient was also a 60-year-old gentleman. He presented with tremulousness of right upper limb and lower limb for last 1 week and inability to see the right half of the field. It was acute in onset, and he had a past history of CVA affecting his left side. In 2018, he recovered almost completely, so he stopped his antiplatelet after 1 year of stroke. He was a non-diabetic, non-hypertensive, but was a heavy smoker, and he was non-alcoholic. So I'll show the video of the patient. So here you can see his left side was affected in the last stroke, and this is the new symptom that he has developed on the right side. He had tremor in the rest position, in posture, as well as during intention. And during finger nose test, you can see that he is not able to see on the right side of the field. On examination, he had on right side, the power was good, but he had rest, postural, and intentional tremor. On left side, he had power, residual weakness, power of 4/5 with dystonic posturing. So this is the MRI image of the patient. I would like to apologize for the poor quality, but it showed the acute infarct in the PCA territory. So patient, he was the weakness, that tremor has already developed 7 days back. So we started him on dual antiplatelet and statins. For tremor, we started him on symptomatic therapy of levodopa plus carbidopa, initially half tablet TDS, and then we increased it to a full tablet on day 3. And tremor almost disappeared on day 4. I'll show the video of day 4. So it's almost completely gone. So this patient had Holmes tremor. So any comments from the experts?
What was the cause of the Holmes tremor?
That in fact, in the PCA territory, in the occipital region,
The new one or the old one?
the new one.
Okay, okay. Yeah. Okay, okay, got it. Yeah.
So this was a Holmes tremor, also known as a rubral mesencephalic or thalamic tremor. But these tremors are now not used because patient may have lesion beyond these areas. Like in our patient, he doesn't have any lesion in the midbrain or thalamus. So we all know.
Ma'am, where was the lesion in this patient, ma'am?
Pardon, sir?
Where was the lesion in this patient?
I'll show the MRI images once again, sir.
Okay, in the posterior circulation. Okay, okay, got it. Okay, the parieto-occipital region.
Yes, sir.
It can happen with cerebellar. It can happen with midbrain,
Yes.
frontomedullary junction. Can have a various. In fact, they talk about multiple areas being involved to produce that.
Can it happen here also in parieto-occipital junction?
Yes, a non-thalamic.
Parieto-occipital, I was okay. I'm not. We're not aware of parieto-occipitals. And one of the good treatments to use in this case is levetiracetam. We have used levetiracetam in many of our patients with good success.
Okay.
Okay, go ahead.
We had our Niman's forum where they actually taught us this point, and it has been quite useful to us.
Okay, so levodopa therapy has been tried in the case series that I just showed. They have tried in 24 patients out of 29. So it was it showed improvement in around 54% of cases. In resistant cases, we can give Botox, and in the patient who are very disabled because of that, we may try thalamotomy also. So as sir told, we can add levetiracetam also in such cases. Just to emphasize that beyond antithrombotic therapy, the symptomatic therapy is also very important in stroke patients.
Yeah, this is a, yeah, please go ahead. Please go ahead.
Just so concluding, Holmes tremor, it's a tremor of 4.5 hertz frequency, which is present in rest, posture, as well as intention. It may develop between 1 to 24 months after the CNS insult. So the patient may have latency. And most common cause is vascular lesion. Most common sites are midbrain, thalamus, but other lesions can also cause Holmes tremor. And treatment with levodopa and the lesional surgery seems to be effective, along with the levetiracetam, as Sir told. Thank you.
So this brings to attention the spectrum of movement disorders following acute stroke. Once in a while we see it. We see sometimes hemibellismus. I have seen dystonias acutely, I'm saying, not chronic, acutely dystonia, which was very difficult to control, but eventually it got controlled. And myoclonus I have seen following acute stroke, hemibellismus, myoclonus, dystonia, and eventually they settle down. What is your experience, Meenakshi? Movement disorders in acute stroke?
Seen hemibellismus quite a bit, sir. And
how
this
is their
Holmes tremor
response?
also many of our patients. Holmes tremor, yes.
How, do they do well in your experience?
Sir, earlier we were using actually trihexyphenidyl, sir. Frankly, they didn't really help much. I have not tried much of levodopa, but after levetiracetam came, it has really changed our thinking, I thought. That is the one which I have tried with best success.
They were tremors or they were focal seizures?
They were tremors only, Holmes tremor, typical, sir.
Okay.
There are videos of that before and after levetiracetam.
Okay. Rahul, what is your experience? No, you're mute.
Not very. Yeah, sorry. Not very good with any treatment option for this kind of tremor. You know, the thalamic kind of tremor or this so-called Holmes or rubral tremor are very notorious for treatment. Whatever you try, it doesn't work. We have tried clonazepam, beta blockers, anticholinergics, then of course levodopa, even antiepileptics like levetiracetam. But my personal experience, nothing really works in these patients. Usually, sometimes some patient would respond to one drug like levodopa at times. I mean, whatever anti-epileptic that we have used, I have not seen any good response. But in this patient, I believe there has to be probably a small infarct which we have not seen, either in the midbrain or maybe in the thalamus, which is probably not picked up in this patient. Because, you know, it's a PCA infarct. So there is a chance that he or she may be having the patient may be having a thalamic infarct. So there has to be a lesion which has produced this, right? So which we are not picked up on the MR.
Yeah. So what was the mechanism in this patient? Mechanism of stroke? What did the workup show? He had a arteriopathy.
He had a previous history of stroke and he was a heavy smoker. He had dyslipidemia also.
Okay.
Cardiac workup normal, man, because one side, right side, then no left side.
Pardon, sir? The carotid, we did the
cardiac workup normal.
Was normal. Ejection fraction was normal. There was no, we did Holter monitoring also. That was also normal.
The reason why we ask is because one side, right side, second time left side. So better have a TE on this patient because our management might change a bit. We'll bet on anticoagulation.
Or maybe a longer Holter for a longer period.
So Rahul, what is your experience of this extended Holter? Because we did in many patients, we hardly get atrial fibrillation, even up to 2 weeks.
Nowadays, a routine one, we have started doing at least for 2 to 3 days. Our cardiologists usually say that do it at least for 3 days. So now,
but are you getting in 3 days any atrial fibrillation?
Started doing 3 days, 7 days also in some patients. We have definitely improved. The yield is definitely improved. In last 3 months, I remember at least 2 patients where we have picked up paroxysmal AF by doing a extended Holter. So yield is definitely improving. So I mean, I can't tell you the offhand data, how many % the yield has increased, but at least 2 patients I remember in last 3 months where we could pick it up and then we could treat them in a different way.
Yeah, but I don't have that experience. I'm doing up to 2 weeks only in ESIS, but we are not picking up. What about you, Meenakshi? Are you picking up?
No, sir, not much pickup for us. We are doing it. Usually we do it for 1 week in our hospital, sir. But unfortunately, we have not been very successful in that. Sir.
So then I read that you should do it for 3 months. Now it's very impractical to do for 3 months. Then the cost will be so high. But
Last time you taught us minimum of 2 weeks, sir. So I try to tell the family that you
Yeah.
go for 2 weeks.
Yeah.
But it is usually, but most of our patients we have done only for 1 week, sir.
Mhm.
He says, yes, definitely we try to do that. Right now, I put one patient on Emcure.
Yeah. So I think good case. Any other comment, or we can?
That
Yeah.
Crystal AF trial and Embrace trial actually showed data like that, isn't it, sir? About 7 days is what they actually said. We were all very fond of that, but somehow it has not materialized in practical experience for us.
That's true. And how is your experience of detecting PFOs with TEE?
Hardly any, sir.
No,
For us, hardly any.
the reason I'm asking is that I did some
How to
PFOs.
study,
I did some PFOs when that data came, no, to close and all, and I did at least 2-3 patients. But these days we are studying ESUS. It's a thesis with all of our students. So we are doing T in everybody, and we are doing Holter in everybody 2 weeks. But yield is not that high. And if you see that ESUS data, the latest trial also, I think it was called Accord trial or Accordion trial, something in which they have shown that it hardly makes a difference.
Yes.
That is also a little discouraging, because our whole idea is to detect something.
Yeah.
So
we are probably doing a similar thing, sir. We are what
Yeah.
we. I mean, I given thesis to my student that we are looking at if the patient has stroked once and then he stroked second time, then probably
Yeah.
we are doing more thorough evaluation to see whether we have missed initially 24 hours, we have missed this, and then maybe do it a longer Holter and see whether there was an AF which was missed on initial evaluation, etc.
Yes,
So we are
yes,
working on second cause of stroke. Someone who has stroked second time, whether he has missed the medicine, whether there's the clopidogrel resistance, whether the mechanism is different than what we thought initially, something like this. And there are quite a few patients, I would say.
yes. So how are you? Are you doing any genetic studies on clopidogrel in those who are having recurrence?
Yes. We are doing, and I'm surprised to see that the incidence of patient who have got resistance is not very low. I mean, quite a few patients have got resistance. There are some who have got intermediate resistance.
Yes.
So there I have started using either ticagrelor or maybe using 150 milligram of clopidogrel.
Yeah.
That's what I'm doing. Higher dose or maybe use ticagrelor in some patients. So my use of ticagrelor is started increasing after doing this clopidogrel resistance.
Yeah,
I don't know there is going to be a cross resistance. We don't know, because both the drugs are from the more or less similar class. So I don't know whether
ticagrelor is supposed not to have resistance because it's not dependent on that CYP. Right.
219. Yeah.
So any other comments?
For aspirin resistance, sir?
We can't check aspirin resistance, unfortunately. I mean, at least not commercially. What we check commercially is only clopidogrel resistance at present.
Yeah. So any other comments, moderators or anybody? Because we had only one speaker today, so we finished in time.
Nice cases, sir. Thank you.
Anjali did a fantastic job. Keep it up, Anjali.
Yes.
Yeah. Thank you.
Keep it up. Thank you. Okay. Then we will hand over to organizers. Prajitka.
Thank you, sir. Thank you very much for your expert comments and providing great clinical insights on these 2 cases. Thank you, Dr. Anjali Choksi ma'am, for presenting 2 excellent cases, and I'm sure audience must have enjoyed. So today, around 152 people have joined online for this case studies. And a big thank you to Dr. Rahul Kulkarni sir and Dr. Sundaram sir for their wonderful moderation. And last but not the least, I would also like to thank audience for joining with us today. Thank you, and see you soon with another interesting case very soon.
Thank you.
And good night. Thanks a lot.
Namaskar.
Thank you.
Thank you, sir.
Thank you, sir. Thank you.